This week we are covering person-centered therapy. So, Carl Rogers is one of the main developers of this approach, and person centered therapy is also known as humanistic or humanistic existential therapy. And we'll talk about that here in a little bit. So, Rogers, again, you're continuing to see this movement away from Freud. Rogers thought that being warmer, being optimistic towards clients, that was a better approach than psychoanalytic. So remember, going back to psychoanalytic, it was very deterministic, it was very driven by the therapist, and so definitely moving away from that. Remember, Carl Rogers was around in the 1900s, and so the only options that were available during that time were psychoanalysis and behavioral therapy. And so he basically broke away from those and started to create and play around and really start to do research. He was one of the first individuals that started to do actual research around, therapy and therapy approaches and what did all of this look like. Rogers, in terms of his research, he basically would try something out, and if it didn't work, he would like, all right, let's get rid of that. And so a good metaphor to use would be a funnel. He would try something, it worked, cool, keep this. It would try something, didn't work, maybe get rid of that. And one of the big things to pay attention to with Rogers is that there was this approach of, I as the therapist am not the expert here. And so if you think about this time frame, if you, for example, went to your doctor would tell you what to do, give you some medication. And so Rogers definitely took this shift away from the therapist being the expert to we are both the expert, or you as the client are also the expert because you are the one who has lived your experience, you're the one who has lived your life. And so that was a very different approach from kind of historically what therapy had been, what the approach had been. And if you think about this, this is actually really cool because it makes the client part of the process so much more than maybe they were in previous situations where I'm the doctor, or I'm the therapist, I'm the one with all the knowledge and expertise, so let me tell you how to fix your life. So one way to think about this is, again, going back to, if patients show up to, say, a hospital or are viewed as patients, what does that do? Within therapy or within counseling or within psychology, words and terminology is very important. And so, what is you saying that someone is a patient? What does that do? Well, patients tend to be historically kind of very passive, right? You go to your doctor tells you what to do, you do that thing, and hopefully you get better. Um, and so there's this move or the shift to someone being a client. And what does a client do? Well, in terms of Roger's approach, it's all right, you are part of this process, you are an active member in this. How do we work together for you to, become better or move towards self-actualization, which we'll talk about here in a couple slides, as opposed to you continuing to, take this passive approach where you come in and I'm supposed to fix you. Now, again, patient versus client, sometimes those are used interchangeably now. It depends on what setting you're at. So if you're at a setting where, say, you're in a hospital or a clinic where it's very normal for people to come in and be called patients, then it's, I would say, probably still very normalized to call someone a patient in that type of setting. But outside of that setting, I think much more the terminology client is used as opposed to patient. Personally, as a therapist, I don't want my patients or I don't want my clients to be passive. I want them to be actively involved in the therapy process. I don't want to foster any type of dependence on me as the therapist, right? Because the idea is, basically to work myself out of a job as individuals, get better or achieve whatever their goals are in therapy. They move on with their lives and they essentially don't need me anymore, would be the goal there, or the direction that we would try to move. And so, while it is a non directive approach, there is this idea of definitely having the client work together with whoever the therapist is, this team based approach, if you will. But definitely still very non directive, very much the client is in charge. as opposed to what we've seen in past therapies, as I've already said. There are no techniques, so this is also kind of very different from what we've seen in previous examples where there is a tool or there is a technique that you're applying in therapy. Psychoanalysis had several different techniques that we talked about. It's in terms of Rogers' approach and person-centered therapy, it's very much about your attitude as the therapist and your relationship that you're developing with whoever that client is. So you are the tool in therapy, which again, very different. And I think Rogers he probably received some flack for this because again, think about the time. And so I think your textbook talks about that Rogers was kind of ahead of his time in this approach because I think he definitely got some feedback of like, dude, what are you doing? Like this isn't how we do therapy, that type of thing. Um, and you might see this or you might kind of pick up on this a little bit in terms of my approach to teaching. I know that it can be very difficult to take a class online, and definitely some of that person-centered or student-centered approach is probably lacking. You're not getting the same thing that you would maybe in an actual classroom where we could interact, we could talk face to face. But you probably definitely pick up on, I try and keep lectures interactive as much as possible. You'll see a couple of exercises for this class, so a little bit different. I try and keep things interesting. I'll throw in memes when they're appropriate to be thrown in. So trying to keep things as student centered as possible for you guys so that you get the most out of this class as possible. It's something that I'm passionate about teaching. I love teaching this class, but I definitely want you to get something out of it, and not walk away thinking or feeling like, oh, this class was a waste of my time. So I've kind of already talked about this slide just in terms of we had psychoanalytic, we had some behavioral therapy approaches, we had Adlerian therapy. We'll talk about some other behavioral therapy approaches a little bit later in the semester, but those were basically the two examples or the two options, historically, and then Rogers came along and kind of really changed the game, if you will. So we have experiential and relationship oriented approaches. So person centered therapy, Gestalt, which we'll talk about, falls within that. And then within that, we also have humanistic, existential, or existential humanistic, however you want to say that, which I alluded to a little bit ago. And so there's a lot of overlap within this, but there's also some major differences. So existentialists tend to acknowledge the stark realities of being human or the human experience, such as anxiety, death, meaninglessness, isolation. Whereas in contrast, humanists tend to be more optimistic. They tend to view each of us as having natural potential and that we can find meaning in our lives. So there are some differences there. And, I think it's important to also acknowledge that this tends to be very philosophical in nature, to some degree at least. Because if you think about it, you know, anxiety, death, meaninglessness, isolation, those are very big topics. And those are very big topics for a client to kind of wrestle with. Um, you know, if a client comes in and they're exploring like, well, what is the meaning of my life, or what gives my life meaning, that's going to one be very different for every client that you see. John as a client coming in is going to have very different meaning to his life versus Jane or Bill or anyone else that you see. But also exploring what that meaning looks like and having a conversation about it can of course be very philosophical. It's not something that you can just say like, okay, here's the meaning of my life and kind of wrap your hands around it, if you will. Again, it's something that's not, there's no technique here, right? So it's having that conversation, exploring with the client, asking open-ended questions. Well, what does that look like for you? What would it mean for you? Or what would your life look like if you did have meaning? What does it mean to have lack of meaning or meaninglessness? What does that look like for you presently? And often that comes out through anxiety, through depression, those types of symptoms. And so, it can be a very, I don't want to say fun. Fun isn't the right word, but it can be um, very beneficial for the client to explore that conversation, to have that conversation. Because again, these types of topics aren't something that we tend to talk about in our everyday life. Like, hey, um, you know, um, I keep going back to Anne as a therapy name, client name. You know, if Anne comes to for therapy and say she's 45, middle age, or say she's 75, any age really, you know, and she's has this fear of death or this fear of passing away or this fear of not achieving the things that she wants to in her life, to have that conversation, one, it's not something that you just have over dinner, like, hey, I have a fear of dying. Pass the potatoes, please. And so, again, having that conversation can just be very beneficial to explore what does that look like for you? How do we overcome that? How do we get past this? Emotion focused therapy. So, this is an offshoot or this grew out of Rogers' work. And you'll start to see this more and more as we move on into different therapy approaches, where, again, there's over 400 different therapies. There seems to constantly be some new therapy approach that's being developed. And so, it's not something that we'll spend a whole lot of time on, but if it's something that interests you, definitely go look it up, find more information about it. And so, emotion focused therapy tends to, there's kind of two primary focuses. One is individuals who experience little emotion or no emotion, helping them access those emotions, helping them start to experience those emotions. And then conversely, individuals who experience a lot of emotion, helping them kind of contain that and bring that into a point where it's manageable for them as clients. This approach also includes increasing awareness of emotions. A lot of times we use I feel for everything. I catch my dad doing this a lot. Like, I feel like going to the store. Like, okay, well, that's not an emotion. So where's the emotion within that? Like, you're thinking about going to the store, but there's no emotion in that statement. Or I feel, you know, what's another example? Um, I feel like, you know, that person shouldn't have cut me off in the road. Like, okay, well, again, that there's no feeling there. You know, you're having the thought that that person should not have cut you off, but where's the emotion there, right? Where is the feeling that you're actually saying? So I feel frustrated that that person cut me off, or I feel excited about going to the store. So increasing awareness of what the actual emotion is, because a lot of times we're not necessarily aware that emotion is occurring. Being able to enhance that emotional regulation. I kind of talked about this a minute ago, but if you're experiencing a lot of emotions, or if you're experiencing very intense emotions, so for example, significant depressive emotions, significant anxiety, that type of thing, anger, irritability, being able to regulate those emotions. Um, so essentially transforming emotions and figuring out, okay, how do I manage these? How do I experience them in a way that's healthy for me as the client? Maslow's hierarchy of needs. So again, you'll see this continually kind of coming up, where Maslow criticized Freudian psychology for what he saw as this preoccupation with the sick and the dark side of human nature. He believed that there was too much focus and research and orientation towards depression and anxiety and negative emotions, and essentially thought that there was not enough focus and research on joy, creativity, self fulfillment, more of those healthy, more optimistic emotions, healthy, positive emotions. And he believed that individuals, that we could become self actualized, that essentially once our basic human needs were met in terms of physiological needs, food, water, shelter, safety, etc., once those basic needs were met and we moved kind of up this, you know, this pyramid, that we could reach a point of being self-actualized, and we could focus on, you know, what he believed were factors that were maybe more important, such as freedom, genuinely caring for other individuals, being creative, you know, using creativity to express meaning, to express what's important to us, acceptance of others and ourselves. And you notice as I'm talking about this, maybe that this shares a lot of commonality with what grew into positive psychology, essentially the idea that, you know, how do we live a fulfilling life, or how do we live our best life, if you will. We'll talk about positive psychology a little bit later in the semester. So clients come to therapy in the state of what Rogers believed was incongruence. And the 10th edition, if you have that of the textbook, uses an example of a student named Leon who sees himself as a future physician, but his grades currently are below average, which would probably prevent him from getting into medical school. And so the discrepancy is how he sees himself currently, or where he's currently at. His grades are likely going to prevent him from getting into medical school, which could likely cause some type of symptoms such as depression, anxiety, versus his ideal self. He wants to get into medical school, he wants to become a physician. And so that discrepancy is what Rogers would say would likely result in someone coming into therapy. And so it can be very cool to have a conversation around the client's real self versus their ideal self, and helping them kind of bridge that gap, if you will, to, okay, well, this is where you want to get to. So, how do we help get you there? What are the steps that need to happen? Let's have a conversation about this and explore this. And part of that can be very philosophical, as we've already said. Like, what would it mean to be your ideal self? What would that look like? And part of that can be very kind of not physical, but like something that you can actually put your hands on. Like, okay, what are the steps that you're going to do between now and next week? What are the things that you're actually going to do, action oriented, to go make this happen? So there can be kind of a mix of things in terms of how you actually approach it. What does that actually look like for you as the therapist and for the client in terms of having that conversation, and moving towards whatever their ideal self is. But again, according to Rogers, this is something that would bring someone into therapy as the client experiences that incongruency. So Rogers believed that these core conditions needed to be present for therapy. He believed that we as therapists should be genuine, should be authentic, should be open, and express feelings, thoughts, reactions, and attitudes. And this is done through careful reflection on the part of the therapist. So, not impulsively just sharing, like, oh, yeah, my aunt died too, and, it was really hard on the family. Like, no, no, no. Self disclosures need to be made in a way that, one, is appropriate, that is well timed, and that has constructive intent from the therapist, or that is constructive for the client. So, essentially, a question to ask before making any type of self disclosure, sharing a thought, sharing a feeling, sharing an attitude, either toward the client or about the client, is asking ourselves as therapists, if I share this with the client, will it benefit them? Will it help them, or if am I just sharing this because it's going to make me feel better, or am I just sharing this because I feel like talking right now? So paying attention to what's going on internally, and is it going to help the client? But again, you're seeing kind of this shift in terms of being authentic. And Rogers would say, and I've experienced this as well in therapy, if you're not authentic with somebody, if you're not genuine with someone, they can pick up on that. Like our therapy clients are not stupid. They can definitely pick up on that. And so it's beneficial, in my personal opinion, to be more genuine with someone, as opposed to, to feel a certain way about them and try and hide that, because more than likely it's going to end up coming out and they're going to pick up on that. Many of you guys talked about being empathic in your strengths in one of the discussion posts, which is really cool to see. Rogers believed that empathy is a deep and subjective understanding of the client. So, understanding the client, being present with the client. It's not about feeling sorry for the client, but it is about being able to understand their feeling and their worldview without becoming lost in it. So, for example, clients sometimes come in, and whatever they're experiencing, significant depression, anxiety, whatever it is, we as the therapist can feel that, but we need to not lose sight of who we are, lose sight of our identity, or our own feeling, our own separateness as a therapist in our identity. So essentially, being able to feel it without being lost in that storm of whatever the client's emotions are. In terms of unconditional positive regard, this is essentially the idea of, you catch more flies with honey, not vinegar. And so Rogers believed that this was accepting the client as they are. A lot of times, clients experience a lack of acceptance from, say, friends or family, or just the world in general, right? The message, if you pay attention to it, is, we don't accept you, or I won't accept you until you change. So if you start to pay attention to this, either in what your family says, what friends say, or even if you just start to pay attention to it in TV shows or movies, it's also often communicated as when you lose weight, or when you stop smoking, or when you insert whatever behavior it is that the family or the friend or society as a whole wants to see, right? Like magazine covers are all, thin models or individuals who are a certain way or look a certain way. And so there's definitely this, maybe lack of acceptance that our clients often feel when they come into therapy. And so, again, Rogers thought or viewed, if we accept individuals where they're at, this, unconditional positive regard, I accept you where you're at, as you are, who you are right now in this moment, that was a healthier approach and that was more beneficial to therapy and to the client. Um, and if we think about this a little bit more, realistically, if you go to therapy and your client's like, and your therapist is like, oh, you're a little overweight, you definitely need to change. I don't like this about you, or I don't like that about you, or your attitude sucks. You're depressed all the time, or you always see the negative side of life. Like, if that's how your therapist talks to you, how likely are you to stay in therapy? Probably not, right? You're going to be like, oh, this therapist doesn't feel me, or doesn't understand me, or isn't supportive of me. You're probably going to go find another therapist. So, just wrapping that idea and then leading into this slide. So, I think this is a very interesting question, and it would be really cool to have a discussion around it if we were in class. Are people doing their best? So, kind of in line with this idea of unconditional positive regard or acceptance of the client where they're at. Do we as therapists, or do you as a person, believe that whoever you know, do you think that they're doing their best? And if you take this approach that you think that people are doing their best, how does that change? How does that change one, our approach as therapists, or how does that change how you approach individuals in your everyday life, whether at school or at work? How does that change maybe our assumptions towards people or about people in any setting that we're in? So yeah, I think this is a fun and interesting question. Um, I think if we approach it as, if you say no, people suck, they're not doing the best they can, they're just slacking off and being lazy. What does that look like, or how does that change your attitude, or your approach, or your assumptions about people? So it's kind of this polarized, opposite. Yes, they are doing their best. No, they're not. Or if you were somewhere kind of in the middle, what would that look like? What would your approach or attitude be? What would your assumptions about people be? Would there kind of maybe be this value that you're placing on it? Like, well, this person I think is doing their best because they set an alarm, they're clearly trying, but they're just not quite making it. Like they have a car that's falling apart, they're like paying some of their bills sometimes, but maybe not all the time. I don't know. I think it's just interesting, and there's kind of this maybe a spectrum of, are people doing their best? Yes, I think they are. Are people doing their best? No, I don't think they are. And what do you guys think? What are your thoughts around this? I think it's an interesting question. So Natalie Rogers took her father Carl Rogers' work and she expanded it. She believed that all individuals have this innate ability to be creative, and she thought that this involved, basically any type of creativity, and a lot of it involves either like a body movement, so dance, choreography, drama, etc. If you enjoy being creative, almost anything that's artsy or artsy fartsy can be used in therapy. So, art that involves your hands, so for example, pottery or knitting, can be super helpful, especially when working with individuals who have suffered or experienced some type of trauma, or have a diagnosis of PTSD, because it gives them something to focus on with their hands while they're talking about whatever that trauma is. So, if we go back to emotion focused trauma, you know, individuals who have emotion focused therapy, sorry, individuals who have experienced some type of trauma, that can be very difficult to talk about, or individuals who experience a lot of emotion, sometimes that can be very difficult to talk about. And so having something to do with their hands is actually shown to be really beneficial, because it gives people something to focus on while they're talking about whatever it is that can be difficult to talk about. So it's basically a way to help get people, a lot of times if clients are talking about something, they can end up shutting down or end up just kind of avoiding the topic altogether. Whereas this is a way to kind of help them through that. So here is one of the exercises that I'm including in this week. So take a moment to reflect on what makes you happy, what makes your heart happy, what makes you feel good, what words would you use to describe whatever that thing is or whoever that person is, what images or colors come to mind, and I will make sure to put a PDF of this into Canvas for you guys. This is another exercise, so this is an alternative option. So for this exercise, you'll start by just kind of grounding yourself, taking a few deep breaths, and make sure that you're comfortable. And we've all experienced something where life is really hard. It's maybe been a really difficult day, and so if we think about being out to ocean in a boat, because this is a lighthouse, um, you know, the sea has gotten black. It's choppy. It's cold. It's rainy. Water's flowing into the boat, and you're like, I just need to get back to land. I just need to get back to where it's safe. You've maybe lost your way trying to get back to land. You're out at sea, and you suddenly, finally, off in the distance, see a light, and it's a lighthouse, and it's showing you the way back to safety. And you start to head towards that lighthouse. So now take a moment. I didn't put a picture here on the slide because I didn't want to, impact what you end up drawing or what you come up with. But draw or paint or color a lighthouse as a source of guidance for you, and depict whatever would come up for you as that guidance or as that thing that's bringing you safely back to land. So, motivational interviewing, this is a fun technique or approach, and this was developed in the 1980s by William Miller and Stefan Rolnick. It's become, and I don't think it's a certification now, but you can definitely complete, 2 to 3 day trainings on it if it's something that really interests you. And it can be very beneficial to use depending on, again, what the client's presenting concern is or where they're at in their stage of change, which we'll talk about in the next slide. And so this is known as OARS, is the acronym. So open-ended questions. Well, if we think about it, what happens when we ask closed-ended questions? So for example, did you get upset at your husband? Yes or no? If the client says yes, like, well, they say yes. Like, that's oftentimes, especially if clients don't want to talk, like, that's the end of it. Yes, I did. What happens though if you change that closed ended question into an open ended question? What do you feel when you get upset at your husband? Well, now the client could talk for days, like, well, when I get upset at him, I feel this and I do this and I react this way. You can see how the answer there can result in someone saying much more than just yes or no. And so it can be very beneficial to ask open ended questions. One, because you're going to get much more of a response from the client oftentimes, but two, it opens up that communication in a way that's much more effective. Affirmations, so this is what it sounds like: affirming the client for the work that they're doing, how far they've come, the changes that they've made, even if those changes feel to you, maybe as a therapist, very small. Again, we're meeting the client where they're at, we're having that unconditional positive regard, and so affirming them for whatever change they've made or whatever they're doing to move towards, that ideal self. Reflective listening. So this can sound, there's several different phrases that you can use. One is, what I'm hearing you say is dot dot dot, or correct me if I'm wrong, insert whatever. So for example, correct me if I'm wrong, but it sounds like you feel frustrated when your boss comes and yells at you. Another one is, help me understand. So help me understand what's going on here. You say that you're experiencing this emotion, etc., etc. Another one is, on one hand, you feel stressed at work and taking smoke breaks helps you feel de-stressed, but on the other hand, you've talked about how you want to stop smoking and you want to set a healthy or a positive example for your kids. So help me understand those two. So that is reflective listening. And reflective listening and summaries are both very beneficial because it communicates to the client that you're listening and it helps them feel heard within the therapeutic space. And then summaries are what it sounds like. You're summarizing whatever the conversation is that you just had with the client. I won't use an example because I don't have an example off the top of my head, but you're summarizing. So, in terms of motivational interviewing, there's 4 processes, and you can see here from the picture that you're going to engage, you're going to focus, you're going to evoke, and you're going to plan. And essentially, you're not going to move to the next step until the current step that you're in has been achieved or has been that you've worked through that. And this is important because a lot of times, and I know that I have made this mistake more times than I can count as a therapist, especially a young therapist just starting out, where I wanted to jump straight to planning. Like, okay, between now and next week, you're going to do this, you're going to fix this, you're going to do this homework. You said you're going to, do XYZ. That's the plan. That's what we're doing. Um, but what we as therapists need to do is slow down and really engage the client. And that goes back to the previous slide of ORS. So, again, helping the client feel understood, helping them feel heard, but also exploring what is their motivation for change, not just like, okay, you said you want to change, now go make it happen. So, really establishing that working relationship. Again, Rogers and person centered therapy is hugely about the relationship and about the therapist's attitude towards the client. So engaging that, developing that, and that's really the bedrock. So therapist, if you're using motivational interviewing, might spend several sessions even really focusing on this stage without even getting to the next couple of stages, or without even focusing on the plan quite yet. Because with the idea being that once this engagement stage or the therapeutic relationship is really strong, has that strong foundation, then you can make a lot of work happen because you've built that strong foundation. Clarifying their agenda. So again, this is what does the client want to focus on? What are their goals for therapy? Not pushing what we want for them onto them, not pushing our own values or beliefs or whatever it is onto them, but really focusing on what do they want? What are their goals? Exploring motivational interviewing. It's in the title. Exploring what is their motivation for change. Why are they changing? Going back to a previous slide with an example. I'm hearing you say on one hand that smoking helps you de-stress, but on the other hand, you want to set a good example for your children and you want to be healthy and you don't, want to expose yourself to lung cancer, whatever, etc. So exploring what that change is and eliciting that change from them to then move into that next stage of planning, developing a plan, and helping the client move towards that action. Essentially here it's if you're trying to force change, if we as therapists are trying to force change, or if the client's trying to force change without doing all of these steps leading up to the plan, um, the likelihood that change is going to happen is probably kind of small. And again, this is reinforcing the client is the driver here, right? So they're the one in the driver's seat. They're the one saying, this is where I want to go, or this is what I want to achieve. So, stages of change. Essentially, this is, if we jump towards that planning session or that planning focus too fast without exploring where the client is and what stage of change they're in, then, again, that change might not occur. So, you can see from the slide, it might be really small. There's different stages. And so pre-contemplation is the person, they might not even know that change needs to occur. They might not think that they need to change. So for example, might be someone who has maybe experienced a DUI or a DWI, but says, I don't have a problem with drinking. I can quit whenever I want to. I'm going to keep doing what I'm going to do. Or maybe they're at a point where they're thinking about change, like, I don't know, maybe I need to change, but that seems like a lot of work. I don't know that I want to do all that quite yet. I'm not really there. Whereas in the next stage, contemplation, they're at a point where, like, okay, I think I'm ready to maybe start to take some action or start to consider what that action might look like. So this might be someone who does initiate therapy or says, okay, I'm going to go see a therapist. I think I need to start to work on this. And then there's moving into actually taking action. And then there's, okay, so you've taken action, and now it's called several different things, but basically maintenance, um, and making sure that whatever that changes, that that client stays in that phase. Or if there is some type of, like relapse, okay, what are the steps that would need to be taken for when that relapse occurs to help move you back towards where you want to be? And these are my references. Let me know if you guys have any questions, comments,